Well, good day, people. This is one of the Florida State University series on substance use disorders. And what we're focusing on today is co-occurring disorders with those substance use disorders. My name is Robert Walker. I'm a retired assistant professor from the University of Kentucky. Prior to being in the university, I spent almost 30 years as a clinician in a community mental health center and was later director of that center. I then went on to the university for about 20 years of research in substance abuse. With me is Jane Dwyer-Lee, who is a teaching professor at the College of Social Work at Florida State University. And Jane and I have been collaborating on a whole bunch of things over the past 4 or 5 years in the whole area of substance abuse treatment and education around substance use disorders. So what we're putting you all through here today is kind of an overview of some issues with treating people with co-occurring conditions. Well, first off, we have to recognize that science has continued to discover a whole bunch of conditions that interact with substance use disorders. So it's not just one thing that interacts with substance use, it's a whole bunch of different conditions that play a role with the development of substance use disorders. And every human condition is very complex. So if your mindset is, let's just focus on drugs or alcohol, and you don't keep your eye open to other things that are going on with that, you're probably going to miss the boat. So substance use disorders and co-occurring disorders also tend to arise from some of the same sources in our central nervous system. The number of co-occurring conditions, at least as we identify them in science, is always expanding. Some conditions actually result from substance use disorders. Others are made worse by substance use disorders. And still other conditions contribute to the difficulty in treating those substance use disorders. So early thinking on co-occurring disorders really only focused on depression and anxiety. These were the things that you may have seen literature on this before. They talk about dual diagnosis cases or dual diagnosis problems. And what they were looking at is just this kind of composite of some anxiety and depression along with alcohol use or other substance use. Well, part of the problem for us all in the field is that as we've discovered more and more disorders that co-occur with substance use disorders, it raises the question of what the dickens are you supposed to deal with first? And one school of thought was that you really ought to focus on that substance use problem first and then worry about mental health problems after you've dealt with the substance use disorder. Well, a bunch of other people thought, no, let's do that the opposite, because if the mental health problem is really driving the substance use disorder, we better treat that first, and that way we'll kill the substance abuse problem in the process. So the type of treatment that was called was serial treatment, one after the other after the other. And that was the predominant thought for quite a number of years. The problem was nobody knew what to deal with first. It was a lot more complicated than just saying, oh yeah, it's obviously a substance abuse problem. And another thing to think about with that is that our overall neurophysiology, and that's neurophysiology is your brain chemistry and the anatomy of your brain, both of these in process. The neurophysiology of the substance use disorder is really not separable from the neurophysiology of other mental disorders. So here we've got an image that looks at if the person with co-occurring disorders is kind of in the middle of two forces, if you will. They've got substance use disorders which disturb your neurophysiology and cause changes in your brain chemistry and changes in your anatomy. And you've got, on the other hand, mental disorders which result from and contribute to changes in your neurochemistry and your neuroanatomy. So these things are not only working on each other, both of them are working on the brain and arising from the brain in very complex ways. Here today, we're going to focus on 8 types of co-occurring conditions. And we're going to see that they each have things that are sort of in common, but also some things that mark them as very distinctly different. We're going to look at affective and mood disorders. That's the anxiety and depression stuff. We're going to look at post-traumatic stress disorder, bipolar disorder, the schizophrenia spectrum disorders, personality disorders, a little bit of attention to attentional deficits, and we're going to look at chronic non-cancer pain conditions, which have played such a role with opioid dependence. And lastly, we will look at traumatic and acquired brain injuries as well. So let's think about some common origins of co-occurring conditions. We now know from current neuroscience that substance use disorders and most of these co-occurring disorders share common origins in child, adolescent, and adult development. That is, these things don't just arise out of nowhere. They're not like the COVID virus that you simply get from someone from minimal contact with the world. They're things that originate in your whole developmental history. And one common theme to all of these is the neurodevelopment of what we often refer to as the disturbed arousal system in the central nervous system. Now, this is particularly important with affective and mood disorders, the anxiety and depression spectrum, but it also plays a role with the others, as we will see. It begins with fetal exposure to maternal substance use and maternal stress during pregnancy. Both of these can affect the central nervous system in its early developmental period in utero. And then probably most important, at least what contemporary science tends to really stress for us, is early childhood exposures to stress, intense conflict, neglect, also have a huge effect on our developmental life and the very formation of our early psychological being, if you will, and our early physiological being. And the effect of those early developmental exposures is that they tend to lead to increased vulnerability to substance use disorders and to many of the co-occurring conditions we're going to look at that arise later in life. Well, another thing just to be thinking about, when we think about substance use disorders, they originate primarily during adolescence. We have some people who begin their substance use age 9, 10, 11 years old. Those are extreme and relatively rare cases. But their use at that age is generally not quite understood as a disorder yet. It's seen as a problem, but not a disorder. But by the time a 16-year-old is making heavy use of marijuana or other substances, we're now likely to call this a full-fledged substance use disorder. And likewise, the major affective and mood disorders, the anxiety and depression, begin to become recognizable conditions during adolescence. And one of the things you might, as you think about your clients and your understanding of how people develop some of these various disorders, one time period that I think is worth a lot more attention than we sometimes pay to it is what's going on during adolescence. Adolescence is probably the most stressful period in all of human development, because you've got essentially people coming out of childhood where the universe has been relatively benign to them, even in situations where they've been exposed to abuse or neglect. There is a tendency to not really recognize the fully harmful consequences of some of those exposures. When we get to adolescence, we now are exposed to a whole range of new competitions. There's social competition, there's intellectual competition, there's physical competition, sexual competition, a whole host of areas in which we're now being tested against other people, and social rank comes out of that. And the degree to which we experience intensified stress from that new competitive world has much to do with how we're going to cope with our anxiety and depression. And it plays a big role in formulating some of that vulnerability to substance use disorders and to mental disorders as well. Think about this in terms of rough developmental stages, if you will, in terms of your neurophysiology. And here I'm not talking about your personality per se, but just in terms of your central nervous system. This is based on the work from a psychiatrist named Bruce Perry, where we start out with some genetic inheritance factors, and they contribute to how our brain stem is going to develop. Brain stem has to do with fundamental basic arousal and awareness of the world around us. It then, however it develops, it contributes stuff to the diencephalon, which is a little bit higher up in the brain organization, but still primitive emotion arousal stuff. And that then contributes to what we call the limbic system, which is sort of in between your higher cognitive areas, your reasoning processes, consciousness, and these deeper emotional systems of the brain. And then the limbic system passes on its stuff to the neocortex, which is where we do our thinking, our conscious thinking. Now, the catch here is that if there is a flaw that happens at that brainstem area, it doesn't go away. It gets passed on through up the cycle. So you can't just go back and fix a flaw that was set at age 18 months. It's pretty much going to be there for the rest of life. And what we're going to be doing in interventions using that neocortex later is teaching people how to cope with what may have happened in their early neurophysiological development. Now, here is another way of thinking about, or a schema maybe, to think about both the evolution of substance use disorders in a person and same for co-occurring conditions. We start out with genetic vulnerability. That's the bottom ring there, the little blue symbol. And so we all inherit different genes and so forth that contribute to how we become people. But it's not simplistic. You don't just inherit a gene for alcoholism. If there is anything that contributes to alcoholism in a genetic sense, it's probably some 100 different genes that play a role with that. It ain't one. And so we have that genetic inheritance, and then we have fetal exposure to substances and fetal exposure to high stress in the mother, both of which have been known to cause a major impact on how our squash develops. We then have early childhood maltreatment, which is, if you looked at weighting all of these on this scheme, probably that one, the number 3, is the one you would give the most weight to, because that early childhood development probably plays a greater role than anything prior to that. You know, upwards of something like 50% of intellectual disability is attributable to low stimulus during early childhood, to neglect during early childhood, impoverished environments in early childhood, not some genetic factor. Well, we move from those early childhood developmental sequences then into adolescence, which we just talked about as being kind of a real intensification of social competition, intellectual competition, sexual competition, physical competition, all of which put enormous stresses on our neurophysiology. And we cope with those better if we've had good earlier development. We cope with them much more poorly if we've had bad events in those early developmental periods. And so with adolescence, we now get the emergence of disorders. We now begin to diagnose certain conditions like depression, attentional deficits, which we may have detected earlier, but they're now very manifest. And we even begin to see the seeds of personality disorders and substance use disorders, which are at the top of our list here. So this little schema might almost be something you would think about in terms of doing your psychosocial assessments with people. You really would want to make sure you cover all the bases that are in those 6 steps. Looking at that, I keep stressing this early childhood exposure. This is a schema looking at those exposures which have been referred to as adverse childhood experiences. And once that body of research got into the literature, we saw that having adverse childhood experiences was directly and strongly associated with all of those bubbles that you see arising out of it. So if you have those adverse childhood experiences, you have a greatly increased risk of incurring brain injury at some point in your life. And that's because these early childhood events tend to limit your ability to inhibit impulses. And that means you tend to have more risk-taking behavior. And if you have more risk-taking behavior, you have greater likelihood of brain injury. Likewise, you're more likely to experience depression, anxiety, or run into PTSD kinds of experiences. You're more likely to have early and unintended pregnancies and problematic pregnancies. You're more likely to have sexually transmitted diseases and HIV, even more likely to experience several forms of cancer, diabetes, and heart disease, things that we typically thought are just physiological, but it looks like physiological stress and distress actually play a pretty important role in our vulnerability to those conditions. You have a much greater likelihood of having alcohol and drug problems, and you have a much greater likelihood of lower academic achievement and lower employment and lower socioeconomic status. Now, another way of looking at this and thinking about this is an image that is a composite of some brains, 13 different brains, male and female. And what they're showing here is as you see those images get progressively more purple, that's telling you that that neocortex, the outer edge, if you will, of your brain, is finally fleshing out with the kind of neurons and connectivity that are associated with what we call gray matter. This is where a lot of the our thinking occurs, if you will. And the important thing in these images, as you look to the right side of those brains, that's the front. Just the opposite. The left side is the front, and you see that the region of the brain that is slowest to get purple or reddish coloring to it is the frontal lobes. And what that tells us is that the executive parts of the brain, the rational reasoning parts of the brain, are the slowest to develop. And so our deep inner emotional centers are all fully fledged by age 14, 15. But our ability to control, manage, moderate those isn't really available to us until we're in our early 20s. Another image of this. Now notice in this brain, I just put this in as to give you an example. This is a 4-year-old brain. And look, if you will, I think you can see my cursor here. If you look at this area, and this is the front right frontal dorsal lateral part of the brain. This is the front, here's the back. This region right here is where we tend to control impulses and manage intense, difficult feelings. So in the 4-year-old, we can see that this brain has not really well developed to do that yet. And in many of the people that we work with as substance use disordered clients and people with co-occurring conditions, they have underdevelopment in that very region of the brain, either due to events that happen to them in life or due to injuries that occurred to them in childhood, early brain injury, etc. So Something for us to be cautious of with all of that is that as we start thinking about doing diagnosis of persons, we want to be very careful to pay close attention to this developmental detail, those 6 steps that you saw in the earlier slide. We want to be really open-ended about our theories about substance use disorders, because if you're really locked into a very narrow disease model or a very narrow mental health model, you're going to miss some really important stuff. So another one is to be open to change with new information, because the longer you work with the person, the more you learn and the more changing stuff that may emerge. You want to be open to that. And you want to be attentive to the role of substance use disorders in every single aspect of that person's life, because that may be where you see it impinge upon some of these co-occurring conditions and triggering some of those as well. Now, we also have to be mindful in our understanding of this kind of co-occurring condition, that there is one group of disorders that kind of confounds this, and we have to be careful about it. Many of the disorders that you see in a DSM-5 include a variant called substance use or substance-induced variant of that disorder. So yes, there are certain mental disorders that look like full-fledged mental disorders, but in fact, they're nothing but the product of a drug that a person took. So we need to be careful and discriminate that. Usually allowing a little bit of time will help clarify it. If you spend a little bit of time with the person, you'll get this clarified. This is really important in looking at some of those schizophrenia spectrum disorders, where somebody could have taken a hallucinogenic drug and appear to be a full-fledged individual schizophrenia, and it's not. It's purely chemistry at work. But there is we have to be respectful of the fact that it's sometimes very difficult to tease out what's the real disorder that's driving this system. Patients will help us get through it. The model to think about as we go through these 8 different types of co-occurring conditions is probably best conceived of as what we call integrated care, where you treat the whole person. And that means that simultaneously, literally within a single session, you're going to address the substance use problem, you're going to address the mental health treatment needs, and you're going to address wellness. Now, I throw wellness in here more in the sense of our preventive work that we do with people. That is, how to head off, how to, in the substance abuse realm, we talk about that in terms of some relapse prevention and watching for triggers. In the mental health side, we look at it in terms of things that have triggered intense emotion, environments to stay away from that might trigger intense emotion. So we want wellness, we want the formal treatment issue addressed for both substance use and the co-occurring condition throughout every session. Let's pause here for a moment and we'll all take a break, and we'll come back in just a few minutes and look at each of these 8 disorders. Okay, let's look at each of these 8 co-occurring conditions. First off, the one that's most commonly associated with substance use disorders, the affective and mood disorders, the anxiety and depression. And one of the main reasons we want to focus on this is that there is actually a synergistic effect between these disorders and substance use disorders, as well as the substances themselves. The CNS depressants like alcohol and opioids and tranquilizers have this acute intoxication effect, but probably more critically, at least for our understanding as clinicians, is they also affect the long-term manifestation of the disorder. So they really contribute to the disorder in very disturbing ways. So The reason people like alcohol, even those with depression, is that it has a powerful euphoriant effect, makes you feel good. But in spite of this being kind of a self-medication effect that alcohol does to relieve anxiety and immediately seem to relieve depression, its long-term effect is to actually increase the likelihood of depression and depressive illness. So it's one of these cases where the self-treatment idea actually works to the harm of the individual. Well, what lies behind affective and mood disorders? Among all the many factors that contribute to anxiety or depressed mood is, again, this disturbed arousal system. And that very disturbed arousal system, by which we mean kind of a sustained anxiety and sort of depressive take on things, that disturbed arousal system can manifest itself in many different ways. It can manifest overtly in anxiety disorder, in depressed mood, intense emotional distress. As it develops, as that arousal system develops, it is extremely sensitive to these early childhood exposures to stress. So by age 2 to 3, like we were talking before, it tends to get set. And you might think about this way. If somebody were building a house and they put in the heating and air conditioning system and somebody sets the thermostat at the wrong level, they set normal as 85 degrees in that house. Well, with the human being, that thing is set for life. It can't get reset. The only way to compensate for that is to turn on the air conditioner at the same time the heat's on. And that's essentially what the person is doing with the substance use disorder. They're hot, and so they try and cool it down with the drug. And of course, it doesn't work. It works for a moment, but it drives the system crazy. And that's essentially what we're looking at with this early developmental glitch that happens to people. It is manifest to us in induced fear states. That is, we have higher levels of fear states among these persons. And that fear might manifest itself in anxiety, depression, and substance use disorders as well. They're also affected by our fundamental temperament, but that's another issue to look at another time. We get, potentially, with that thermostat set, we basically get two different types. We get people who get it set too hot, and we get people who get it set too cold. And we're looking at people who get hyper-arousable from their early childhood experiences. That means anything that's a variation from the norm makes them anxious. And then we've got hypo-arousable types for whom they can't get enough stimulation. And so, if you're looking at what temperament do you want in an airplane pilot, a jet pilot, we want the hypo-arousable guy to do that. We want the guy who, when you're losing 10,000 feet per minute, he's still sitting there very calmly at the controls trying to pull the plane out of the dive. If you had a hyper-arousable type person, they'd be going nuts in the cockpit and we'd crash immediately. But in terms of how this affects us with substance use disorders, etc., it works both ways. The people who are hyper are more sensitive to the distress in life and typically want central nervous system depressants to calm them down. The people who are hypo-arousal, on the other hand, really like stimulant drugs to boot them up and give them a buzz in life. They're bored to death just sitting there. So both of these are temperamental structures that interact with our early childhood development and get aggravated. They get made worse, whichever one we have. So both of these temperamental structures with early childhood problems get worse and increase our substance abuse risk. Well, extended periods of stress experience lead to all kinds of physiological changes. We secrete this hormone called cortisol. And if it stays in our system for a long period of time, it actually is related to killing off some brain cells in our core emotion systems, in our memory systems. And overloaded burden on that arousal system is also related to this thing called allostatic load, this is where a person's burden of stress has reached a level where they can't deal with it anymore. It's just too much. And for the person who's vulnerable to substance use disorders, they cope with it with drugs or alcohol. So these chronically disturbed arousal conditions, hyper or hypo, both contribute to increased risk for substance use disorders and mental disorders. Now, what do we do to cope with this? Well, our brains have evolved a really unique system for coping with some of this arousal stuff. We turn to the reward system. And that's where, like, about an hour before I did this program, I had some chocolate, because chocolate triggers my reward system. I limit myself to 4 pieces a day, but I have them almost every day. If I had many more than that, we could call me a chocoholic, but I'm not there yet. The reward system is one of those devices that the human physiology gives us to try and cope with our distress, if you will. This is a cartoon that shows a couple of the key regions. Right here, if you follow my cursor, you see the thalamus, and this is where all input from our visual and auditory and sense, all of our senses, get kind of read and given an emotional stamp. If that stamp is that the thing we're looking at is fearful, it sends messages to this little thing here called the amygdala. And the amygdala, if it senses fear, a need for fear or fight or flight, if it's turned on, it triggers a whole cascade of neurotransmitters and cortisol release from other glands. It's kind of your distant early warning system. It really inflames our stress response. And sitting right under the amygdala is the hippocampus, which is our memory storing and memory retrieving system. So if we're an individual who is highly stressed, all of this is tightly woven into these core nuclear parts of the brain and intimately tied to our memory system. Well, this image gives us a couple of different things. This little AMI is our amygdala. So if we're distressed, we get messages going all sorts of places in the brain, but also notice that we hit the nucleus accumbens, and that's where the reward center is. And it relays information to the ventral tegmental area. Here's the hippocampus again, our memory system. So we've gotten stressed, we remember that stress and we hate it. And excuse me, we remember, if I take a drink, I'll feel better. And so that gets looped into the same memory system. So each time I get intense distress, I know how to get some relief, some euphoria by having a drink of alcohol or opioid or benzodiazepine or whatever. And that gets routed actually through the whole brain. And in particular to this limbic system, which is in between the thinking areas and these inner emotional areas. So whether I have depression, anxiety, chronic pain, you name it, all of that stuff gets mediated right here in this limbic system. Social pain gets felt here, getting high gets felt here. Well, with depression, my encouragement to you is to take it very, very seriously. Depressive symptoms, which almost always include a feeling of hopelessness, is a major troubling factor in almost every illness and health condition we want to name. Recent research even links depressive symptoms to a greater risk for cardiovascular events like heart attacks and strokes. It also plays a role with cancer. Whether it's caused by substance use disorders or is incidental to substance use, or whether it is always co-occurring with substance use, it deserves focused attention because it's going to make things worse if it's not dealt with. Now, social workers can address mood, anxiety, and substance use triggers all together, and with depression as well. A session can look at all of these things as a mixed bag. And substance use, which can provoke depression and anxiety, even as the person is using, them to ward off, that's important information to share with people, that the stuff you're doing to self-medicate is actually causing you some harm. So as we approach this, one of the things that I encourage people to do is to remember that for most, not all, but for most people with substance use disorders, their default mental state, that is their basic mental state they wake up with each day, is very unpleasant and it feels unnatural. And they really only feel natural and brought back to normal if they're high. So one takeaway here is that as long as we focus on mental states as a way to both address mental health problems and substance use disorders, we're probably on the right track. Now, some caveats here. I've said we want to do integrated treatment, but if a client clearly presents to you in an intoxicated state, you got to deal with detoxification first. That's just got to be absolutely primary. There's no sense in dealing with co-occurring disorders when the person is still intoxicated. It's just a waste of time. However, being aware of the fact that they likely have co-occurring conditions might guide the kind of detoxification you do. So we want to get them stably detoxed, not just detoxed on their own with no observance, no support system. Those co-occurring conditions might affect how we set that up. Now let's look at post-traumatic stress disorder. PTSD, we know, intersects with depression and anxiety. And trauma experiences point to both all kinds of mental disorders, really, but primarily depression, anxiety, and PTSD, as well as substance use disorders. And not uncommonly, people who've been exposed to not a traumatic event, but multiple chronic kind of traumatic events may exhibit traits of personality disorders. Many studies give us really high rates of women in substance abuse treatment who have PTSD. This first one here suggests 60%. I've seen others that suggest 80% of women in substance abuse treatment have trauma histories. There are important differences between early childhood trauma and adult trauma, and the combination of those two very important, because then you're looking at both kind of the neurophysiological instantiated effects of early trauma, along with the psychological and biographical memory of traumatic experiences. Combination of these two make it very complicated to treat and much more difficult. There's a high risk for dissociative disorders among women with substance use disorders and PTSD. And the real sticky wicket here is that substance use can trigger those as well as mask them. So that's something that requires some kind of careful diagnostic work. Homeless people are very likely to have PTSD as a co-occurring condition with their substance use disorder. Excuse me again. So we want to pay very close attention to the likelihood of these two conditions amongst persons with who have sustained homelessness. The overall relationship of PTSD and substance use disorders is very complex and it's synergistic. By which I mean this, continued substance use with a trauma history can re-invoke, can revitalize some of those memories as well as suppress them. So it has a very complex and curious, sometimes ironic association, that is the substance use has that with PTSD. The physiological and psychological distress that originate from PTSD can actually act as a motivating reason for substance use. So again, self-medication hypothesis probably plays a role here. Another worry is that recent research has shown that trauma exposures are associated with psychotic experiences, with the greater number of exposures associated with more severe psychotic experiences. Now, looking back in time, PTSD used to be treated as a psychotic condition. It really isn't, but there are certain class of individuals who begin experiencing psychotic experiences and possibly have schizophrenia along with PTSD. yet another complexity for our co-occurring condition. In terms of treatment, the seeking safety approach is, I think, kind of ideal because it treats the trauma and the substance use disorder right in the same session. And it is it's a concurrent or integrated treatment approach. It's gotten good reviews in the research literature and is one of those things that's fairly easy for social workers to practice because it's got a whole bundle of different techniques to roll into the services. The intensity of PTSD experiences makes sequential treatment less appropriate. That is, you probably do not want to think about treating either the substance use condition or the PTSD independently, one before the other, because they're so interactive with each other. Persons with substance use disorders and PTSD can present with very unclear intoxication states. They can begin having flashbacks and dissociative symptoms that may be caused by intoxication or triggered by them. Again, spending a little bit of time and being careful and methodical here will eventually get you through this, but it can be very confusing. Safest intervention is to first assume that the substances do account for the very disturbed presentation, but being vigilant throughout this detoxification is really important. This is not a person you want to detoxify by themselves and unobserved by others. Lots of the different substances can have the effect of triggering or exacerbating the symptoms of PTSD. Lots of different approaches are used in treating PTSD. Social workers should be most likely prepared for fairly lengthy treatment with PTSD as a co-occurring condition. Medication history is not great for PTSD. There are all kinds of articles that come out suggesting ketamine or whatever. Their sustained and replicability is not very good. So I'd be careful with that. Long-term support and coping capacities, which is what seeking safety is about, are probably our best route. Bipolar disorder. The risk for substance use disorders among persons with bipolar disorder is extremely great, very high. Central nervous system depressants like alcohol, benzodiazepine, sometimes opioids are often sought during the manic or the high periods of bipolar episodes. And sometimes stimulants are used when they're during a depressive phase. As with PTSD, sequential treatment is unlikely to be helpful because the intensity of these mood swings in bipolar disorder will just unseat any substance abuse treatment if it's not addressed simultaneously. The treatment that is most usually sought during depressive episodes. Most people with bipolar disorder do not want treatment when they're in the manic phase because they feel great. They're on really the equivalent of a cocaine high. And so they don't want to be interfered with. But during the depressive period is when they're more likely to be open to treatment. And management of both conditions is really paramount. You really got to be working with them on both the manic and the depressive phase. Most substance abuse or many substance abuse treatment programs and professionals try to avoid using medications during treatment other than things like our medically assisted treatment like buprenorphine. But the medications that are used for bipolar disorder don't really interact terribly much with the reward system of the brain, so they probably ought to be widely endorsed. Careful management of both treatment needs, both the substance use and the bipolar disorder need concurrent treatment, concurrent attention. One without the other is most likely to fail. If you've got one with opioid use disorder, obviously medically assisted treatment is a possibility, but be careful. Be careful about manic episodes being confused with intense intoxication to methamphetamine, cocaine, or other amphetamines. They look very similar. You usually get a little bit more of a physiological response to the amphetamine high, sweating and so forth, but not always. A person in a manic episode may exhibit those as well. Detoxification of persons who have bipolar disorder and substance use disorder is best done in a medical environment. You really want medical management in charge here. Not safe to do this in non-medical environments. Treatment for stimulant intoxication involves a lot of vigilance for a whole bunch of medical problems, cardiovascular events, etc. And learning about drug ingestion will be critical in order to judge the likely time of manic-like symptoms. So, for instance, with cocaine lasts a very short period of time, so learning when the person took it may be helpful in understanding the manic-like manifestations. With bipolar mania, it is sustained over days and days, maybe weeks. People who are seen as having these mood changes from mania to depression within the single day, that's not bipolar disorder. That's substance use disorder. That's borderline personality disorder, possibly. If the mania presents much longer than is likely under an intoxication condition, then clients should be referred for psychiatric care because you're probably looking at true bipolar disorder. Schizophrenia spectrum disorders. This includes that whole bundle: schizotypal personality disorder, delusional disorder, schizophreniform. We used to think of this as a more unified kind of condition. It's now understood as having lots of different variants. It's a whole family of disorders. Most of these disorders are marked by problems with the dopamine system. So it means that the emotion system and the thinking systems are kind of not in good coordination with each other. The person will be laughing and giddy while telling you they're depressed and suicidal. There's a disconnection between thought process and affective system. And most of these disorders with their disorder of the dopamine system in their central nervous system, that also interacts heavily with substance use as well. So the substance use disorder can be also synergistic with the schizophrenia process in ways that are very complex. Hallucinogen use is very complex to understand with schizophrenia because you can have people who have experiences on hallucinogens. They're just like an individual with schizophrenia. So again, social history is important. And we also have to be sensitive to the fact that in many instances, these drugs can actually trigger a full-fledged psychotic process. We've now got a fair body of research telling us that early cannabis use, that is early in life, late childhood, early adolescence, age 13, 14, 15, use of cannabis is associated with triggering psychotic experiences and possibly even causing onset of schizophrenia or other psychotic disorders. And as I mentioned in the PTSD section, trauma experiences appear to have a linear relationship with psychotic symptoms. That is, the more exposure to early childhood distressful experiences and trauma, the greater the severity and likelihood of psychotic episodes. Now, again, looking at this developmentally, if you think about the number of individuals that you work with, particularly if you're working in adolescent treatment, there are any number of cases where kids are seen as either having an early mental disorder or having early cannabis problems, when in fact, it may be both of the above. And we've got these steps to think about with the evolution of this kind of co-occurring condition. One, those pre-existing conditions, those early childhood experiences, adverse experiences in early childhood play a role here with the manifestation of the disorder. Then early exposure to cannabis and to alcohol plays an important developmental role. We begin to see in adolescence some of the emergence not generally in child. You don't see this very often at all in early child or middle childhood, but in adolescence, we can begin to see some psychotic-like states, often accompanied by a lot of extreme isolation of the person, which typically associated with cannabis use and associated with early schizophrenia. That leads to increased cannabis use, and then we begin to have the manifestation of formal psychotic illness. So again, this is another one of these instances where you've got a developmental sequence leading to the co-occurring kind of condition. So in treatment, priority should be given to the area of greatest current severity. So if the individual is overtly very psychotic, you want intense psychiatric care for that right now. And that generally is going to mean inpatient, where the substance use problem could certainly be taken under control. But the one element here that is somewhat different from some of the others we've looked at is that in most of these conditions, you're also going to be looking at bundling in some fairly complex social services, housing, employment, etc. Personality disorders. Persons with B cluster personality disorders, that's the histrionic, borderline, narcissistic, and antisocial, are very likely to have substance use disorders. But here is an extremely important caveat. The presence of a substance use disorder also exaggerates tremendously the expression of personality traits. And so persons with substance use disorders are often misdiagnosed as having these underlying conditions. And our treatment history is replete with experiences of people losing their personality disorder when they've got 3 to 5, 6 years of recovery. So it tells us there's an important relationship here between the two. Effective recovery from substance use disorders tends to diminish personality disorders. Well, what goes with these disorders? A propensity to impulsivity, particularly regarding pleasure seeking, pain avoidance, impulsivity, cognitive impulsivity, leaping to conclusions prematurely, as well as behavioral impulsivity. Lability of affect, frequent mood changes, their ability to manage emotion is very, very poor, and their tolerance for negative mental states is very low. They typically have damaged personal and social relationships. Again, what happens with substance use disorders? Same thing. Instability behaviorally, same thing with substance use disorders. And most persons with B cluster personality disorders have histories of childhood maltreatment. Again, think of this developmentally. We start right at the same place for personality disorders as with most substance use disorders. Early childhood trauma, neglect, those adverse experiences. Witnessing violence tends to have an enormous impact on the development of these disorders, not just directly being a victim of the violence, but witnessing domestic violence, etc. Sexual abuse is very prominent in the histories of most persons with B cluster disorders, particularly the borderline and antisocial, less so for histrionic and narcissistic. And early substance use, often as a self-medication. Again, that theory pops up again as it did with PTSD, with anxiety disorders, depression. And then personality and lifestyle adaptations can include characterological accommodations to maltreatment. Now, what we mean here is that literally the shape of personality that comes out of adolescence may simply be the person's best behavioral accommodation to the distressful circumstance of their background. And that also plays a role with the substance use disorder. With personality disorders, we might want to pay some more attention to serial treatment. That is, now placing a little bit more of a role on some longer term psychotherapy kinds of issues, in addition to the substance abuse, maybe putting the substance abuse a little bit after some of this other personality stuff. But if we need to treat the substance abuse first, if we're getting a lot of intoxication states, as we teach management of that, we're also teaching the same stuff that we would with personality disorder. coping with negative affective states, negative mental states, etc. The development of personality disorder coincides with the period of development of substance use disorders. These two things grow up as kin to each other. Attentional deficits. Many persons with substance use disorders also report lifelong difficulties with attention, and many report having been diagnosed with attentional deficit and hyperactivity disorder. Your social workers really want to tailor your interventions with attentional deficits in mind, and what that has is huge impact on your substance abuse treatment sessions. People with attentional deficits do terribly with hour-long sessions. They do much better to have 2 or 3 20-minute, 30-minute, 40-minute sessions a week than to have one real intensive one. And these groups that are an hour and a half to 2 hours long for people with attention deficits, forget it. They left the room after the first 15 minutes. So you don't want to use complex, long sentences. You want to use short, pithy kinds of statements, visual cues. You want to do a whole different spiel with this than what you might do with other persons. Medications, yeah, they work for certain people real well. There's all kinds of literature about increased risk from early use of stimulant drugs to treat attentional deficits. Looks like for some group of people that becomes a precipitating factor and a risk factor for lifelong substance use. For others, it doesn't. You're just going to have to use some good sound clinical judgment here as you navigate that. Many persons with substance use disorders also report learning disabilities that may or may not be related to their attentional deficits. Definitely worth exploring. If you get information about attentional deficits, you want to explore these learning disabilities as well. You want to be mindful of these deficits in verbal or special reasoning that can affect comprehension of what your content is going to be in interventions. You know, if people have processing problems with information, giving your normal spiel ain't going to work. So let's pay attention to assessing these disabilities and attentional deficits. They also can point to a need to refer people to specialized services, speech therapy, whatever. We want to be sensitive to that. Chronic non-cancer pain. Now here we're talking about non-malignant pain. That's non-cancer pain. It has been traditionally poorly treated in the medical world. We have abundant history of people simply getting shunted into opioid medication. That is, the doctor doesn't have time to work with their whole psychological distress. They just write the prescription for the benzodiazepine and the opioid and send them on their way. And we now know that having chronic pain is one of those important pathways into opioid use. It is a precipitating factor and a risk factor. The problem is that chronic pain leads us into opioid use, and the more we use opioids, that is, the higher the amount and the longer the period of time that we use it, it actually leads to a condition called hyperalgesia, which means that our sensitivity to pain increases the more we have used these opioid analgesics. And that increased sensitivity to pain fuels the need for more opioids, and thus an escalation. So we get escalation not only due to tolerance developing to the drug, as we would with any traditional opioid use pattern, but we also have got it because of this hyperalgesia. It's a double whammy. Traumatic brain injury and acquired brain injury. These are the types. A concussion is where you have a direct impact on the brain, and angular movement that results from the brain. Keep in mind that your brain is like a steel case with jello inside. So when we tap it on the side, it sends off these reverberations in the jello inside, and it can slam against the backside, which is what the third one here, the contra coup. I might get hit in the front of the brain, but actually experience most of the damage in the back from the contra coup portion. A contusion is where we actually bruise the brain. We get bleeding in the brain, and that can cause some lifelong problems. Diffuse axonal injury is where the damage is not focal, that is not a little pinpoint area in the brain, but it's affected that white connective matter in the inner portion of the brain, and it's all through the brain. It's a very damaging condition and very difficult to diagnose. Shaken baby syndrome, which has undergone a lot of recent research, a lot of controversy. It's essentially a version of diffuse axonal injury in many instances. Well, we've got literature that tells us that at least 1/4 of the people who are in substance abuse disorder treatment have co-occurring brain injuries. And John Corrigan and Jennifer Bogner here are among the leaders of research on this at Ohio State University. You want to pay attention to their literature. They've done a lot of looking at this. Presence of brain injury in a person with substance use disorder suggests also that they've got a whole host of other things going on that we're going to need to be aware of. So it's like a co-occurring condition that opens the door to a whole host of other co-occurring conditions. So here are examples of it. Here the head is struck in the front, and we hit a hard object, and we get some the traditional concussion injury, which in this instance is right in the frontal lobe, right where our higher reasoning, planning, executive functions tend to be. So this is another example of it. This is looking at the bleeding, the bruising in a brain. So you see right here on the right frontal areas where the person has had bleeding, and much of that will be permanent damage, because when blood escapes into brain cells, it destroys neurons. Neurons do not like blood. This is contra coup. So here we see initial impact here, but as the person moves back and forth, as the head is shaken, you get injury front and back. Now, what happens, as I said, when you've got a brain injury, well, what does the literature tell us? What does the research tell us about people with brain injury? They have this whole gamut of co-occurring conditions that are very likely once they've had at least one injury, and more so with 2 or 3 injuries. Illicit drug use, sleep disorders, very common for people with brain injury. And think about that in terms of alcohol and drug recovery programs and management of sleep disorders. They have heightened risk for depression, heightened risk for anxiety, much more likely to exhibit personality disorder traits. They have increased pain that is poorly managed. That is, they don't respond as well as other people to pain management. They have alcohol misuse, and they have greatly increased. With one brain injury, you have about a 3 times greater likelihood of a second brain injury. And with a second brain injury, you have about a 3 to 5 times greater likelihood of a third. So the more injuries you have, the greater the likelihood of more injuries. What are the implications for treatment? Our interventions need to be very concrete and very simplified. Sessions need to be much more numerous, but shorter, just like what I said with attentional deficits. Specific step-by-step approaches are best, very concrete. Do this, do that, then do this. Simple written guidelines and instructions can be helpful on cards that they can carry with them. The support structures of 12-step recovery are particularly important for these people. Risk avoidance should be a priority, telling them stay away from this person or stay away from this environment at all costs. And techniques for impulse inhibition if they can learn them. Other conditions that we might want to think about. You need to be open to other possibilities, other things that might pop up. Autism is not extremely common. It's a relatively rare condition, but we're seeing more of it in children and adolescents. And there is a complex relationship between autism and alcohol, heavy alcohol use. So that's another one to be careful about. There is some overlap for some persons with eating disorders and substance use problems, though the tendency is for the eating disorder to be the predominant one. Social workers are certainly encouraged to be open to all of these kind of multiple problem areas. You want to be keeping your scanners alert. General guidance here for co-occurring conditions. Managed care wants us to get quickly to a diagnosis and a problem definition. My encouragement is to move slowly. Go with provisional diagnoses. Be very careful with your explanations and conclusions about conditions, because you need to be open to things changing as you get more information. And watch out for a rigid adherence to a particular theory of substance use disorders that might obscure what you're likely to see if you spend a little bit more time with persons. Close attention to people's mood and affect, their mental states, will improve your diagnosis and treatment. And the gateway into substance use disorders and co-occurring conditions is these intolerable negative mental states. So if you're paying attention to that, you're probably on the right track. And treatment that fails to address those negative mental states is probably on the wrong track. You're probably going to fail. So a focus on how a person feels and how a person thinks can anchor a dual target of substance misuse and mental health problems all in one. It's not just dual diagnosis, though. The modal client, the average client in most treatment settings these days, has 2, 3, 4 co-occurring conditions. So think of a client who presents with a depressed mood, alcohol use disorder, anxiolytic use disorder, traumatic brain injury, and a personality disorder. That's not atypical. With a focus on the substance use disorders, while a focus on substance use disorders may have an important organizing function to treatment, social workers must also attend to all of those other nested concerns to get a successful outcome. Thanks a bunch.